Good evening. My name is Joe Moscow. I, along with Brian Springer, are co-chairs for this 60-day MOC review course in adult reconstruction, brought to you by AAHKS, the Hip Society, the Knee Society, AOS, and OrthoBullets. This evening's is on Module 1, which is our first webinar on adult reconstruction basic science. Our renowned faculty is Dr. Jay Parvizi and Adolph Yates, and we will start off with Dr. Parvizi.
Thank you, Brian. Thank you, Joe. Thank you, Derek. It's a pleasure to be here tonight. Thank you very much for the opportunity and for giving me the basic science topics. I'll try to wrap these up in about 30, 40 minutes, and hopefully this will be comprehensive enough to cover some of the topics. But clearly we cannot cover everything in detail. But we will go over the general ideas and also the things that you might be examined on. So let's start with a question. 56-year-old left knee pain undergoing knee arthroplasty 6 years ago. He was doing okay until 18 months ago. Now comes in painful. So the lab's C-reactive protein is 0.1 milligram per deciliter. Please note that C-reactive protein comes in 2 units, milligram per deciliter and milligram per liter. SED rate is 3. Aspiration shows 157 leukocyte and 18% polymorphs. Obviously, this patient is not infected, as you know the threshold that was determined by MSIS and the international consensus is C-reactive protein of 10 milligram per liter, ESR of 30, cell count of 3,000, and differential of 85%. So the answer here would be a one-stage revision, as this patient is not infected. You can see that the patient obviously has loosening around the femoral component, possibly tibia and the patella. So osteolysis around the components is not uncommon. It represents a histiocytic response to wear debris, and wear debris can be either polymorphs, either polys or cement, and it elicits a macrophage-activated osteolysis process that then does result in loosening. Sometimes prosthesis micromotion, particularly rough prostheses that are in contact with cement, can also result in generation of particles that can initiate osteolysis. Types of wear, there's different types. Adhesive, volumetric, and linear wear get asked very commonly. Basically, volumetric is dependent on the size of the femoral head, and linear wear is lower with a smaller head. And the third body is when another foreign material gets stuck between the polyethylene. Talking of polyethylene, highly crossing polyethylene is now the most commonly used bearing surface in both the hip and the knee. The wear rate of the highly crossing polyethylene is roughly 0.1 millimeter per year based on tribology data. And as you know, there are different types of polyethylene from different manufacturers, but overall, the wear rate is approximately a millimeter per 10 years. Factors influences, of course, activity of the patient, alignment of the components, and the initial thickness of the polyethylene itself. Femoral head sizes between 22 and 46 millimeter don't seem to influence the wear rate of highly crossing polyethylene. Ceramics and other type of bearing surface, lowest wear rate amongst everything else, and the wear rate is almost negligible. The only problem you might see with ceramics is a stripe wear, which is as a result of liftoff or micro separation during the gait, and it can lead to squeaking, and it can also lead to possible fracture, although that has not been proven. Recurrent dislocation or incidental contact of femoral head with metal shear can also cause what's called lead pencil-like markings that leads to increased femoral head roughness and possibly increase the femoral polyethylene wear. Metals, they have smaller wear particles as well as lower wear rate, 2.5 to 5 micron per year. Titanium is not a great bearing surface. You need to remember this one as it is not sensitive. Metal-on-metal wear stimulates lymphocytes, not macrophages, has been asked in the exam commonly, and it is dependent on the size and also position of the components. Macrophage activation sets up a whole cycle of molecular mechanism that involves cytokines as well as interleukins. In particular, TNF-alpha, TGF-beta are involved. Interleukins, in particular interleukin-1 and interleukin-6 are also involved. These activate the prostaglandin cycle, and they can lead to increase in the level of these cytokines and activation of VEGF and also rank and rank L activation, which we will come to in a few slides. Let's talk about this commonly asked question again. A polyethylene cup is shown in figure A that's been sterilized in packaging that contains oxygen. As you know, packaging in oxygen results in increase in free radical formation and damage like this. So you will be expected to know this in the exam, which obviously oxidation as a result of formation of free radicals and damage to the polyethylene. And because of that, now polyethylene is sterilized in an inert environment. Another question of highly crossing polyethylene, low susceptibility to fatigue fracture and provocation and joint arthroplasty. Which of the following will result in the lowest susceptibility to fatigue crack? As you know, unfortunately, fatigue crack can happen with the highly crossing polyethylene, and the mechanism by which highly crossing polyethylene is produced does influence the mechanical strength of the polyethylene. And direct compression molding from polyethylene appears to reduce the mechanical strength the lowest. Catastrophic wear and polyethylene sterilization. This is macroscopic premature failure of polyethylene with delamination and large particle production. This is due to excessive loading and mechanical loosening. And the most important factors that influence catastrophic wear is the initial thickness of the polyethylene, articular surface design, kinematics, and the way highly crossing polyethylene is sterilized and manufactured. As far as critical thickness of polyethylene, 8 millimeters seems to be the number that everybody keeps being asked, and that still appears to be the right answer, although that might change with time, and it does change from knee to hip and also whether it's a conforming or non-conforming surface. Articular surface design, basically two designs of the knee. As you know, the deeper congruous joint without the rollback. This maximizes the contact load, increases the contact stress, but a flat tibial polyethylene improves rollback and optimizes flexion, but it increases the contact stress and could lead to catastrophic failure of polyethylene. So flat design of tibia is the one that's associated with the highest increase in failure rate. So congruency of the polyethylene in the knee influences the wear rate as well as the failure. Sterilization in oxygen, not a good idea, and it leads to production of free radicals and early failure. Because of that, now polyethylene is sterilized in oxygen-depleted environment, as we talked about. The methods of production of polyethylene, multiple different times. Ram bar extrusion and machining. This is the one that affects the mechanical strength the least. Sheet compression molding and direct compression molding and net shaping. Not so common question in the exam, but you certainly need to know these mechanisms and their differences. Causes of failure, machining, shear forces cause subsurface stretching. That's within the 1 to 2 millimeter of the polyethylene surface, especially the amorphous region, more than the crystalline area. And in order to counteract this problem, direct compression molding of polyethylene is what has been recommended. in the old days, you would see this white, classical white band in the subsurface of polyethylene, which was as a result of this phenomenon. Which of the following is true regarding osteoprotegerin or OPG? OPG, rank ligand, obviously BMPs, the function of osteoblasts and osteoclasts. These are all very commonly asked in the exam. And basically, OPG is the antagonist to rank ligand and prevents the function of osteoclasts. Talking of osteoclasts, here is the interaction between different cells. Macrophage activates the osteoclast precursors, and these are, as you know, multinucleated cells. Rank ligand is then activated that binds to active osteoclast. Then a whole series of reactions start and leads to activation and formation of cytokines and interleukins. Rank ligand, very commonly asked, is secreted by osteoblasts and binds to the rank receptor on osteoclast precursors and leads the osteoclast precursor to then mature into osteoclast that obviously leads to activities we'll describe. PTH, common question, activation of its receptor stimulates adenylyl cyclase. Interleukin-1 stimulates osteoclast differentiation and bone resorption. 125 dihydroxyvitamin D stimulates rank ligand expression. That's been asked many times. Prostaglandin E2 activates adenylyl cyclase and also stimulates resorption. Remember, IL-6 and to some extent IL-1 are involved in myeloma-mediated osteolysis, and so is MIP-1A. OPG, as we talked about, is a decoy receptor produced by osteoblasts that binds and sequesters rank ligand and basically inhibits osteoclast differentiation and function. It's important to mention calcitonin interacts directly with the osteoclast via cell surface receptors. Estrogen stimulates bone production and it works through a decrease in rank ligand activity. TGF-beta results in an increase in the level of OPG. IL-10 suppresses osteoclasts. So IL-10 is good. IL-1 and 6 are inflammatory. Question on 65-year-old complaining of intermittent knee pain, 12 years after total knee. And basically the patient comes in with pain and the radiographs are here, as you can see, loosening of the component, particularly the femur, and there's areas of osteolysis underneath the tibial tray. And this is again question is trying to test your knowledge of what the thresholds are for the aspiration and whether this is representative of infection or not. As we talked about, 10 C-reactive protein of 10 milligram per liter, ESR of 30. These are the MSIS thresholds, and the cell count of 3,000. So here we have 7,500. Neutrophil differential of 80%, and here's 90. So clearly, this is an infected joint. Granite is negative. We'll talk about this later. Granite is pretty useless. It's unlikely you'll be asked about its sensitivity and specificity. So here, what's the available solution? Well, you could choose between 4 and 5, but it's really not giving you too much information to know whether the patient is or is not a candidate for one stage. So here the right answer would be explantation of the components. Periprosthetic joint infection. So let's talk about that. The incidence is probably around 2% after knees and around 1.5% after hips, much higher after revisions. Active infection is one that occurs within 4 weeks of index arthroplasty or as a result of hematogenous spread of organisms to the implant. And there are some risk factors that result in joint infection. And of these that would most likely you would be asked is immunocompromised status, diabetes, patients who are on disease-modifying biological agents, such as anti-TNF agents, malnutrition, smoking, and excessive alcohol consumption, and obviously intravenous drug abuse. So a whole list of risk factors. Most commonly is gram-positive cocci, but this is an ever-changing science. The more we discover about infection, the more of the so-called non-pathogenic organisms are being considered and recognized as true pathogens. Prophylaxis, screening nasal mipiricin for MSSA and MRSA reduction has been shown to reduce the incidence of infection. It is not known whether that is as a result of the screening itself and or administration of the appropriate intravenous antibiotics, but certainly there are quite a few studies showing that it can lead to a reduction. Urine culture or screening is not warranted preoperatively. The international consensus recommends DMARD being stopped 4 to 6 weeks prior to surgery. We will learn about this more as more studies and consensus statements come out. It is important to administer antibiotics within 30 minutes. WHO has now extended that time to 2 hours. CDC recommends that it's done within 30 minutes. CDC feels that 1 dose of antibiotics is enough, but at this point, 24 hours is the so-called standard of care. If you were to operate in an operating room, very important to operate with a positive ventilation system. Laminar flow certainly is one. WHO, interestingly, is recommending against the use of laminar flow in total joint arthroplasty, but CDC has not made any recommendations regarding the type of operating room. And at this point, we don't know exactly what to do with regard to administration of antibiotics following surgery during dental procedures. ADA, American Diabetes Association, feels that this is not warranted, but most of us surgeons administer it for the first 2 years following joint replacement. Unlikely to be asked in the exam. Acute infection, one that occurs within 3 weeks, but as I said, CDC has extended that to 90 days. It is usually thought that acute can be treated by irrigation, debridement, and retention of the prosthesis because infection hasn't had a chance to cause osteomyelitis, internalize, or cause biofilm formation, although that's debatable now. But when it becomes chronic, it is important to consider removal of the prosthesis as biofilm forms on the surface of the implant that results in the formation of glycocalyx and enveloping of the organisms. History is usually pain. It might be associated with some recent event, in particular wound-related problems, recent bacteremia, ulceration in the extremity, etc. And anytime a patient with a prosthesis presents with pain, infection should certainly be suspected. On a physical examination, usually sinus tract is obviously a definite sign of infection. There may be redness and also drainage, maybe low-grade fever in some patients, and motion is restricted and painful. Radiographs are definitely necessary, but they are not always that helpful. They can certainly show you loosening. Occasionally, they might show you periosteal reaction, which is a sign of infection. They may occasionally show involucrum, abscess formation, and extensive osteolysis, particularly if it's focal, is suggestive of infection. Autoscan, really pretty useless test. Very unlikely to give you much data. Low sensitivity and specificity. And at this point, bone scan should be reserved for cases in which you have attempted 2 sets of aspiration and have not been able to obtain any fluid. PET scan, very useful, but not available widely, very expensive and cumbersome, and its sensitivity and specificity is no better than aspiration alone. White blood cell in serum is really not very useful unless the patient is systemically sick, in which case there is left shift. But ESR and CRPs is still done as screening. And again, we've talked about the thresholds. In chronic, it's 10 milligram per liter. Acute is 100 for C-reactive protein. ESR in the acute setting really doesn't have much role, but in chronic, 30. Serum markers such as interleukin-6 have been tested in the past, but it appears that their level seems to be affected by the time from surgery, much like C-reactive protein and ESR. Thresholds are not absolutely determined, and interleukin-6 is not available in all centers to be done, but a useful test nonetheless. MSIS criteria, you should really know this. Major criteria, which is sinus tract or a pathogen being isolated from two separate tissue or fluid, and minor criteria when 4 out of these 6 criteria may be present. The diagnostic algorithm, we won't go into too much details, but basically American Academy recommends that you do lab test, C-reactive protein and ESR, and the next step would be aspiration of the joint. And aspiration should be sent for cell count, neutrophil differential, and culture. And at my institution, we also do leukocyte esterase, which is part of the MSIS, the international consensus criteria. Gram stain, pretty useless, as I mentioned earlier. And if you have aspirated the joint and you did not obtain any fluid or adequate fluid, the best is to re-aspirate the joint in another occasion. Microbiology, definitive diagnosis can be made if the same organism is obtained from the culture or the tissue. Histology, useful, particularly in cases where you suspect infection but haven't been able to prove it. The most important thing about histology is you must obtain it from an area where there's not too much of fibrin, exudates, etc. And secondly is that your musculoskeletal pathologist who reads the histology needs to be familiar with the samples being processed. At this point, 5 PMNs per high-power field in greater than 5 high-power field is probable for infection. Molecular testing, PCR, molecular markers such as alpha defense and leukocyte, etc. The future is going to be exciting with development of further tests such as next generation sequencing. Treatment. Non-operative is really not an option very much for a fit person. Anybody who cannot undergo surgery may be suppressed with antibiotics, but otherwise it's important to consider surgery. Surgery can be done either as irrigation debridement, retention of components for patients presenting with early infection, well-fixed and well-positioned components, and possibly an infection with a low virulent organism. It is the success of the procedure is very technique dependent. The more of the surgical debridement you do and the bioburden reduce, the higher the likelihood of success for there. What stage? It is an important armamentarium for treatment of these patients available in Europe, and at the moment a clinical trial is underway in the United States to try to evaluate its utility and also determine the indications for this procedure. But the Europeans will agree that you shouldn't do a water stage exchange. A patient who have compromised soft tissues and you're unable to close it, patient who has systemic toxicity and they are systemically ill, and possibly organism has not been identified. So culture negative may not be a great option. Success rate, depending on how you define success, between 75 to 100%. Two-stage exchange, still the most preferred method in North America. I wouldn't call it gold standard, but certainly the preferred method. And it has a success rate between 70 to 90%. And the success of this is really dependent on the immune stats of the host, the type of organism you're dealing with, the degree of osteomyelitis and soft tissue involvement, and also the efficiency and the proficiency of surgical debridement, both during the first and the second procedure. Salvage operation for patients who failed prior attempts at eradication of infection. That definition is fluid, varies from one surgeon to another and from one study to another. But I would say that a patient who's undergone at least two stage exchanges previously should be considered for a salvage operation, which is either resection arthroplasty for the hip, arthrodesis for the knee, and amputation for the knee and possibly the hip. Two-stage exchange, I'm sure all of you know, it involves two operations. The first one is excessive it's attention to debridement of all the foreign material, placement of an antibiotic cement spacer that increases the local delivery of antibiotics, and then reimplantation at a later date. The spacer can be either static or dynamic or articulating, and there are pros and cons to each of those, but the most important appeal of dynamic is that it allows the patients to bend the knee to some extent and become functional with the hip, but they can dislocate, they can fracture, and they can certainly dislodge. The static spacer, on the other hand, doesn't have those disadvantages, but it does carry higher morbidity for the patient and functional compromise. Articulating spacers are either made during the operating in the operating room during your resection arthroplasty or prefabricated. The prefabricated spacers may not contain adequate antibiotics. An elution of antibiotic does depend on the cement porosity, surface area, and the antibiotic concentration. So the higher the concentration, higher the local delivery of antibiotics. And because of that, you might consider fashioning the spacer intraoperatively. Two-stage arthroplasty involves administration of antibiotics for a period of 4 to 6 weeks. That period keeps changing. Europeans believe even as short as 2 weeks may be adequate. But in the examination, you should really choose 4 to 6 weeks of intravenous antibiotic. The most preferred antibiotic is first generation cephalosporin or vancomycin for methicillin-resistant organisms. Reimplantation, when infection appears to be under control, soft tissues have healed, and patient serology is tending towards normalizing. And during this time, you get another opportunity to do debridement. Okay, now we're going to switch gears and go to material properties. What's the most likely mechanism for failure of modular revision total arthroplasty femoral implant at the mid-stem junction? I think this also applies to primary modular stems as well. And unfortunately, it's the micromotion between the components where it leads to a problem. So let's talk about some of the commonly asked questions and some of the terminologies. Basically, all you have to do with these is just to know their definition. So load is a force that acts on a body. Stress is intensity of an internal force, and it's calculated by force over area. Strain is relative measure of deformation of an object. It's basically change in length over original length. And here's the stress strain curve that you need to be very familiar with all the different regions. Elastic deformation is a reversible change in the shape. Plastic is irreversible because the material doesn't return back to its original shape. Toughness is the amount of energy per volume of material can absorb before failure. Creep is the increased load deformation with time under constant load. And load relaxation is a decrease in applied stress under condition of constant strain. Hysteresis, commonly asked question also. It's basically characteristic of a viscoelastic material where the load doesn't follow the unloading curve. Basically, the lines don't match up. FEA or finite element analysis also has been asked. in the past. It's basically breaking up a complex shape into triangular and quadrilateral forms and balancing the forms and moments of each. And it is an evolving science, unlikely to be asked in too much detail. This particular graph, you need to commit to memory and know it, unfortunately, for the examination. I'm not sure if there's any other way of really talking about this. It is the Young's modulus for different material and compares that to cortical and cancellous bone. Brittle material, these are material that exhibit linear stress-strain relationship up until the point of failure. They undergo elastic deformation only and little to no plastic deformation. Basically, they just break. PMMA, ceramics, classical example. Ductile material, they undergo plastic deformation. They basically bend. Metal is a good one. Viscoelastic material is the one that exhibits a stress-strain relationship that's dependent on duration of the load and the rate by which the load is applied. And examples would be ligaments, bone, cartilage. Isotropic material possess the same mechanical properties in all directions, and isotropic different directions. Again, commonly asked questions. How about material? Titanium, as we talked about, is a biocompatible, excellent material for making plates, implants, screws. It is not a great bearing surface because of its knot sensitivity. Stainless steel, on the other hand, has these components, is very stiff, is fracture resistant, but it is susceptible to corrosion and release of cobalt chromium. And cobalt chromium, talking of which, they can result in some local toxicity. They're advanced, they're very strong, and they're better resistant. They have a much higher resistance to wear. Metal characteristics: fatigue, failure, endurance limit, and creep. These are definitions you need to know. Creep is phenomenal progressive deformation of metal in response to constant force. I don't really know how else to talk about these, as you just have to know the definition. Corrosion, galvanic or crevice corrosion. Galvanic is when two dissimilar metals are in electrochemical contact, leading to destruction of the metal. Classical examples: stainless steel, cobalt chromium. Crevice corrosion is when there's a fatigue crack due to difference in oxygen tension. And again, that stainless steel is the one that's most prone to this problem. Fretting corrosion is a mode of destruction at the contact size from relative micromotion. And as we talked about this earlier, the modular stems, the cobalt chromium head on titanium taper of a femoral stem, etc. This is part of the fretting corrosion, and is most common cause of mid-stem failure, again in modular femoral stems. Let's talk about bone a little bit. The composition of bone is either organic or inorganic. In the organic part, collagen type 1 is the most common collagen. Mechanical properties of bone is that it's a very strong material. It is best in compression and not so good in tension. And tension usually leads to transverse fracture secondary to muscle pull. Compression leads to axial loading and crush type, and as bending leads to butterfly fragment, and torsion leads to spiral fracture. These modes of fracture have also been asked in the past. Here's a question. An increase in advanced glycation in products is characteristic of which of the following clinical conditions and results in which pathologic process? So the bone and the collagen and articular cartilage in particular change over time, and their characteristics with age differs with their characteristics as affected by different diseases. So with age, cartilage basically dries, and one needs to be very clear about the process of arthritis and other diseases versus aging. And this is very well described in the module, and I would strongly recommend you to commit this to memory and also understand it for the exam. Articular cartilage is one of 5 forms of cartilage: hyaline, fibroelastic, fibrocartilage, elastic cartilage, and physeal cartilage. We talked a little bit about articular cartilage made of collagen type 2, and it includes extracellular matrix. The cells that are in the articular cartilage are chondrocytes or chondroblasts, and it is very rich in water, and then contains organic material, collagen proteoglycans, and some non-organic material that is a smaller part of the articular cartilage. Most of it is basically water. Chondrocytes produce collagen, proteoglycan, and enzymes. They are derived from chondroblasts that are basically trapped in the lacunae, and they, as you know, don't have much of metabolic activity, but they are active inside the lacunae, and chondroblasts result in formation of immature articular cartilage derived from stem cells. And it's been asked in the past which growth factor drives the cells towards chondrocytes or chondroblasts, and the answer is TGF-beta 1. Extracellular matrix, mostly water, then type 2 collagen and proteoglycans, as we talked about. There is very small amount of other types of collagen, 5, 6, 9, 10, and 11, but most important collagen in articular cartilage is type 2. Proteoglycans, very important. They make up 10 to 15% of the cartilage. Aggrecan is the most commonly found and the one that's most responsible for the hydrophilic behavior, basically absorbing and keeping water. And it's composed of GAG subunits, which are chondroitin sulfate and keratan sulfate. There are multiple layers to articular cartilage. I won't bore you with the details. I'm sure you'll be able to see this from the figures, but and each one of these gets affected by diseases differently. And here is the zones against superficial, intermediate, deep layer, tide mark, and subchondral bone. And it's important for you to know which disease affects which layer of the articular cartilage. Drugs get asked about occasionally, and we'll go through a couple of these that are important. Bisphosphonates are one of them. And as you know, the long-term administration of bisphosphonates results in these subtrochanteric femur fracture, transverse fractures, and that might come up in the exam. Please be careful not to go for femoral neck, because these are just very classical fractures that are in the subtrochanteric region. Bisphosphonates are a class of drugs that act on osteoclasts. They prevent formation of osteoclasts through the ruffled border microtubules. They cause apoptosis of these cells. They inhibit the activity and hence bone resorption. There are 2 classes or 2 types of bisphosphonates, nitrogen containing and non-nitrogen containing. I doubt very much you'll be expected to know these, but it is important for you to that they have different types of characteristics. Osteoclasts resorb bone through production of enzymes at the ruffled border. Here's a great graph that shows the activity and the molecular mechanism of what goes on in the ruffled border. CTK is cathepsin K, is a very important enzyme that has been involved in the process of absorption of bone and has been occasionally asked about. Here we are. To stain osteoclasts, we use the trap staining or tartrate resistant acid phosphate. And sometimes you've also been asked about proteolytic digestion. The organic matrix is removed by the proteolytic digestion and then they are stained. Osteoclasts and osteoblasts are in continuous communication. Here is a result of molecular factors that can activate and influence the osteoclast function. I won't go into too much detail because this is a fascinating science, but requires a lot of our time to be able to cover tonight. Bisphosphonates accumulate in a high concentration of bone due to their affinity for calcium. They are ingested by osteoclasts, and they work by two different mechanisms depending on the presence of nitrogen or not. And nitrogen-containing bisphosphonates inhibit the farnesyl phosphatase synthase enzyme, and they're required they inhibit the GTPase formation, and because of that, the activities through different enzyme pathway than non-nitrogen containing bisphosphonates that work through the apoptosis and cell death. Indication for their use, most important ones to remember is osteogenesis imperfecta, early stage of avascular necrosis, metastatic hypercalcemia, or for that matter, any type of hypercalcemia, including that caused by Paget's. Contraindication, severe renal disease, and patients who've undergone lumbar spine fusion, as it might influence fusion. One of their scary complications beside the subtrochanteric fracture is osteonecrosis of maxilla, the jaw. Okay, antibiotics. Antibiotic classification mechanism. Which of the following is included in safety checks on the World Health Organization checklist? Well, as we alluded to earlier, both CDC and WHO recommend that antibiotic be administered to patient prior to undergoing total joint arthroplasty, and it is very important that antibiotic is given at the appropriate time prior to surgery. CDC recommend that this is done within 60 minutes, and as I mentioned earlier, WHO feels that might be extendable up to about 2 hours. Here is the class of antibiotics, very, very broad and incredibly important to know their mechanism. Fluoroquines or quinolones work through DNA gyrase. Rifampin works through RNA polymerase. And of course, you know the cell membrane inhibitors such as penicillin, vancomycin, etc. Important to know their mechanism of action and also some of the side effects. Cephalosporin disrupts the cell synthesis of peptide glycans, and as you know, peptide glycan is a cell wall, and because of its disruption, the bacteria die. First generation is Ancef, Ciclor, Rosafin, and Maxipin. These are the generations that have been that are available in clinical practice. Vancomycin also works by inhibiting cell wall synthesis, and the vancomycin-resistant enterococci or even Staph aureus have now been isolated. And the gene is VANC-A, which has been isolated in sequence. Fluoroquinolones, they block the DNA gyrase, as we talked about earlier. They inhibit maybe fracture healing. They may result in Achilles tendon or other types of ligament rupture. And one of their other complications, they can increase the QT interval on the EKG. Aminoglycosides work by binding to 30S ribosome subunits, and gentamicin, etc. are some of those examples. MECA gene has been asked for in the past. MECA gene is the gene that signifies methicillin resistance, and Staph aureus that contains MECA gene would be MRSA. Antibiotic resistance is obtained by the bacteria by either altering their cell wall permeability, changing their DNA machinery, by creating biofilm barriers, or altered peptide glycan subunits. And these are some of the mechanisms by which resistance in the bacteria emerges. Which of the following side effect is most strongly associated with use of NSAIDs? Another group of drugs that get asked in the exam. So as you know, NSAIDs can result in cardiotoxicity, all of them. And in fact, so do COX-2 inhibitors, and hence the story of Vioxx and Celebrex. But they can also result in renal dysfunction, in particular renal impairment. They can also result in hypertension. And if the glomerulonephritis is really severe, it can result in hematuria. So even though here it looks like two of the answers may be correct, renal impairment and hematuria, it is asking about the most strongly associated side effect, and that is certainly renal impairment. So anti-inflammatories NSAIDs work through the arachidonic acid pathway, and COX-2 inhibitors, you know about COX-1 and COX-2. COX-1 is in the endothelial cell wall, and COX-2 interferes least with the GI, and because of that it has a selective cytotoxicity, and hopefully you will be asked those questions which are easy to answer. Aspirin also works through the arachidonic acid. It irreversibly binds to the serine COX enzyme. And the other types of NSAIDs all work through that arachidonic acid pathway. Side effects we talked about. They may also result in delayed fracture healing. Nothing has been shown in terms of their effect on osseointegration, although that has been considered to be one of the problems that exist. Finally, corticosteroids. They work through reduction of cytokines and interleukins. They prevent the formation of pre-inflammatory mediated arachidonic acid, and this inhibition prevents the early step in the inflammatory cascade. So I'm going to stop there, and I am sorry if I've gone over a little bit. I hope we've covered some of the most important aspects of the basic science. At this point, I'm going to pass the podium to Chick Yates, a great scholar, another orthopedic surgeon with interest in basic science, who will be covering other parts of the basic science and clinical condition. Chick, all yours. Thank you very much.
Thanks, Jay. I'm hoping that everyone can hear me. Following Jay, I hate to say it, from Pittsburgh, is somewhat like following the Tom Brady of science and orthopedics. But I'll try to press ahead, and we're going to try to cover the high points that are going to help you with your MOC. Again, it's important to just pick out the key phrases and questions. And the key phrases in this particular question is that you're seeing two groups, 100 patients in each, and then you see that 30 patients did not complete. Don't get absorbed with the nature of the study, but look at the overall structure of it. And what you see here is that the 30 patients were included in physical therapy group for analysis, even though they didn't complete the entire process. So the question is, what is this type of analysis? And it's not too complicated, but this is the intent to treat analysis. You don't want to lose the effect of the physical therapy on those patients that dropped out, and the fact that it may have been something that was onerous to them or they couldn't complete because of other reasons. And that's important to capture, and that capture is called intent to treat. So that segues into clinical trial design. In a broad overview, it's either observational, which means there's no allocation of intervention, or experimental, in which case you have randomization. The researchers allocate the treatment. That's the broad overview, and within, if you can remember that, within observational, again, there's no allocation of treatment. You're looking at case series, case reports, and then case control, which would be more analytic. The gold standard for an experimental is the randomized clinical trial. A randomized clinical trial is a study where patients are randomly assigned to treatment or control. That's been an asked question in the past. It provides the most compelling evidence. That's the most important thing to remember. And it minimizes study bias. A crossover design can be used in a randomized clinical trial But the buzzword in a crossover design, that's where you are in one arm for a while and then switch over to the other arm, is that it's susceptible to bias if the washout period is inadequate. Patients can tell a big difference between one or the other if they're very close to each other. The analysis, it has to include intent to treat analysis so that you minimize the non-responder bias. That's what we were talking about with the last question. And the phrase per protocol just sort of includes things like excluding patients who are not compliant with the protocol guidelines, and those can be left out. A cohort study is a study where the patients are not separated randomly, and they are followed prospectively, if possible, or retrospectively. The prospective studies would be level 2 evidence, retrospective level 3, and when you look at these, the word to remember is that you're using a relative risk analysis. Case control studies take the current cases of disease or those without, and they look for whether there was exposure in the past. And in that case, those are level 3 evidence, and again, the buzzword for case control is that you use odds ratio. I think we all know that meta-analysis is the collection, the systematic review of a collection of papers, and it helps to increase the statistical power of several underpowered studies. It's important to remember that a meta-analysis is only at the level of evidence that the lowest paper included in the meta-analysis is accounted for. Moving on to level of evidence, the most important thing is in the middle where I highlighted. Again, it doesn't, you're not getting tested on PRP and the outcome of this study. You're looking for the kernel within the question that helps to answer it. And so the kernel is the study was not randomized, but the treatment and control groups were matched appropriately. And it was also prospective. So the answer to this question, as we alluded to earlier, is that it's a level 2 study. And a level 2 study is one that's well designed, prospective, cohort. It can also be a poor quality randomized controlled trial that would otherwise be level 1, but it has poor follow-up or some other reason to be a lower level, such as an element of bias. And again, if you do a systematic review of level 2 studies, you don't get level 1 results in your meta-analysis. It's a level 2 set of evidence. And if level 1 meta-analysis is non-homogeneous, then you drop down to level 2 as well. So just to go over, level 1 evidence is the randomized controlled trial or meta-analysis of randomized trials with homogeneous results. A level 2 study, and this is really what the questions are usually asked because most people understand level 1, is a poorly designed randomized controlled trial where the follow-up has dropped off below 80%. It can also be a prospective cohort study where they're not separated randomly, and it can also be a meta-analysis of level 2. A level 3 study is a retrospective cohort study, a case control study, or meta-analysis of level 3 studies. Level 4 is a case series, and you drop to level 5 when it's a case report, expert opinion, or a personal observation, and that's in most level 5, most level 4 and level 5 evidence isn't included in the design of clinical practice guidelines and moving into evidence-based medicine. We're going to quickly move to statistical definitions. And so the question is, what term in statistics defines rejecting the null hypothesis when it is in fact true? And that represents a type 1 error. And what that means is that you believe that you have found something that is being caused by the effect. You've rejected the null hypothesis, but in fact, it's not true in the big sense that it has been, that it's real. Just to go over a few definitions, statistical definitions, the definition of sensitivity is highlighted in the graph to the right. And if you look at the top where disease, all the patients that have the disease are with the plus sign, those patients will be picked up as either true positive or false negative. And what sensitivity tests for is how well you test for something that's really there. And this is a fundamental to definition, and most of surgeons will understand this. And of course, the converse is specificity. And if you look at the graph to the upper right, it's the patients that truly don't have the disease, and that includes patients that unfortunately get a false positive and the ones that fortunately get a true negative. And that's that's defined by the true negative over both the false positive and true negative. That tells you whether or not the disease has hit a home run, or the test has hit the home run correctly. Now, a type 2 error as opposed to type 1 is a false negative difference, and it's either because of detecting no difference when there is a difference. In other words, you accept the null hypothesis when it really shouldn't be, and that's the second definition as well. This gets us into power, and the power of a study is 1 minus the type 2 error. So a type 1, again, to reiterate, a type 1 error is when the null hypothesis is rejected even though it's true. And by definition, this means that you've got an error that somehow has exceeded the 0.05 that we use as a probability that there's a 1 in 20 chance of that type 1 error. That's a fundamental definition, and this would mean that the study has discovered something from the effect that that really shouldn't have been accepted. Buzzword coming up: Bonferroni correction. You don't have to think too hard about this, other than to remember that it's a statistical correction. It's actually a simple formula, and it's made to the p-values when there are multiple multiple tests being run on the single set of data. So moving on to question 32, it asks the chi-square test is most appropriate for which of the following? The answer is categorical data, and here's the trick. If you want to remember what a chi-square test is used for, remember that it's a hard C, chi, and categorical starts with that hard C as well, and that's one sort of a mental trick for remembering that categorical data and chi-square tests go together. And again, that's being stated on this slide. Categorical data is that data which has a set number of possible outcomes or possible states. An example would be a dice. There's only 6 ways a dice, one roll of the dice can go, between 1 and 6. A special circumstance would be a dichotomous state or dichotomous data where the answer is yes or no, or infected or not infected. Again, there's a hard C in dichotomous. So yeah, the way I remember this is categorical, dichotomous. It's a little trick to try to remember these things. When the data is collected, when people are looking at the data, you have to know how many groups. Is it numerical or categorical? Again, numerical would be more of a continuous value. It doesn't have to be absolutely continuous. And is the data parametric or non-parametric? And that describes the shape of the distribution. Again, categorical data, chi-square, and the alternative is a Fisher exact test. And that's used when there's less than 5 data points.
This concludes our webinar 1 on Recon Basic Science and Adult Reconstruction. Those who will be following on webinar 2, General Conditions, we will hear the second part of Dr. Yates's presentation.